So the next thing we're going to do is go into the elbow. Lateral glide mobilization with movement is something I do very often with patients. And what I'll do, I'll show you the medial and lateral glide. There is some discrimination of kind of when and where to do it. Honestly, a lot of times I do the pill with these, not necessarily pain free, but I do want it, lessen pain. I want that to be very instant to the patient, and I want that to be long lasting. So what I'll often do is I'll have them do something. So let's say it's a gripping activity. I will have them hold something that they're honestly used to gripping and have them hold on to that. And then either I'll have them do movements with it or even do that regular grip strength and say, does this feel better? Or you can even do elbow motion. So what we'll do today is maybe elbow extension. So what I come in here, hand here on top of the humerus and then on top of the radius, and just put a little bit of a lateral glide onto the humerus. So, and then go ahead and just straighten your elbow out. Perfect. And go ahead and bend it back for me. Just like that. What I do is just get an instant feedback. How does this feel? If it, again, is that pill, that pain-free, it's instant, long-lasting, keep mobilizing into it. Oftentimes with the Mulligan's work, they can do reps of 6. I generally will go to 10 and then immediately translate this into the clinic or work, either with a rogue band or teach them how to do it kind of in a doorway or even hands-on. And the second one you can do is actually the exact opposite. It's coming in onto the humerus here and then onto the ulna and then applying that glide. Go ahead and go down for me. Good, and then come back up. Say you're not getting that necessarily the motion you want or anything like that. Also always remember the elbow works in different ways. So if I'm going down into extension, generally my arm will go into a little bit more pronation. If I'm going into flexion, it'll go into more of that supination. So coupling that motion sometimes is needed to get the best results. Thank you. The next thing we'll go into is humeral ulnar and humeroradial distraction. With humeral ulnar, and I should probably say I do all my assessments and work from the elbow into a supine position if I'm doing a lot of manual. But once we kind of get out of a less manual position, I'll actually go into sitting and actually not do as much manual or do more mobilization with movements. But if I'm doing like humeral ulnar or humeroradial distraction, what I'll do, go right down into here, and I actually will often kneel here. Come in here, grab onto the arm, and I'm going to use my elbow. I'm going to go in just like that. And what I'm looking for is the table should block her, or if it doesn't, you can always get like a belt wrapped around. And I will actually go down and scoop out. Go down and scoop out. The reason I do that is to follow the olecranon's natural movements. Oftentimes this is another subjective inquiry to see if you're doing it right. They'll feel no difference or, oh, that feels so good. That's what you'll actually be looking for the patient. So, and oftentimes it takes, 3 to 5 times just to get that perfect pull, or you can even quadrant a little bit to get that thing that really makes a difference for them. So again, down here, scoop out and block out just like that. The next one for the humeroradial distraction, and this is actually can be a test to see if there's anything articular going on. What you'll do, come down here, just slightly grasp onto the arm at the forearm here, block the humerus from going forward. I pin the radius and I just distract my body away. Come back, distract my body away. So if you'll see it, here, pin, distract my body away. Not pulling, but just that nice little go. Honestly, what you can always do, say that the wrist motion gets pain at the elbow. If you can come down here and grasp, pull away, get them to the wrist motion and it feels better. And then go and add that compression and it gets worse. That actually might pointing to you for articular issue going on or maybe a muscular issue going on, etc. If it's muscular, both of those will be painful. If it's joint or articular, it actually might not be painful when the distraction, if we're looking at just kind of clinical decision making. Crazy kid. All right, so next what we'll show is supine proximal ulnar radial joint mobilizations. So ways that I can do this again, as I'll often have a stool just talking to my patient in this position, honestly, because this allows a lot of blocking on this side. I can go right in here, kind of feel for the radial head. And generally can be kind of irritating, especially right around that radial head area. So oftentimes what I'll do is I'll make sure I'm on it, make sure I'm good, then kind of block my thumb a little bit, mobilize into here, or oftentimes bring the arm down a little bit, go into right here, elbow on the plane, and I can just kind of mobilize as I talk to him. Everything very comfortable, stabilized proximal distal, just going into it just like this. Oftentimes I'm going to mobilize into that if I'm trying to get some type of supination going on. Then that's for the radial ulnar joint. If I want to get a type of pronation, I want to come do the other way and actually do a A to P glide. So oftentimes the muscle can kind of get in the way, so you need to kind of block that out. And since my hands are big enough, I actually can get around and feel that radial radius move and just apply just like this. Just kind of back and forth. Elbow in the plane, kind of go down, easily kind of talk to him, etc. And just kind of go back and forth looking for that motion. This, of course, if you're looking at convex concave, it will help actually get a little bit of that pronation. And I can go further, just changing up my angle a little bit there. But oftentimes, if I'm not getting exactly what I want in the elbow, with pronation, supination, extension, I'll try one way, retest. If that's not working, I will come and do the other way. And sometimes it has good results. If you look at it from the standpoint of where this might actually go into this position a little bit, if that biceps head is irritated and constantly giving a pull to that radial head, when it shifts up in that way, a lot of times going in here and applying an A to P mob can actually be relieving, help get some of that elbow extension, or kind of get some relaxation on those wrist extensors up here at the top. Why that's important is because oftentimes you'll always hear radial head P to A when it comes with any type of lateral apocondylalgia, etc. And why that's so important is because that can be a very difficult thing to treat. Anything we can do to get a little bit of irritation off those structures can be so helpful, and oftentimes the joint is quite can be quite involved. Honestly, whichever way through test and retest feels better is something that we might want to go down, even though it might not fit that convex and concave rule. Two last things we'll look at in the elbow is, of course, radial head manipulation, where I can go onto that radial head, pin it right there. And oftentimes, if I'm doing this in supine, what I will do is kind of come into here, kind of block down, just kind of mobilize, and just let the patient know, hey, I'm just going to give you a little quick stretch, go down, and then just thrust into there. Oftentimes, in this position, not necessarily is this beneficial because of that kind of give that you just saw. So I actually like to come in here, block on the ulna, my hypothenar eminence, my pisiforms over here in the head. I've got the ulna blocked. Go, and just go like that. And then, of course, retest. Another way we'll look at is a Mills manipulation that can actually be beneficial as well. The final thing for the wrist before we go into that is going down into the extensors. It's called a pin and stretch, where you can easily come into here holding down and going into that wrist flexion just like that. So pin it, extend it, just like this. I will be honest of myself, I don't do as much of soft tissue as that way. I kind of hold to the paper done, I believe 2013, about the fascia interface and possibly not having that much friction to it. So the idea of holding, pinning this down and moving, we might not actually be doing what we think we're doing, though if it causes a neurological physiological effect and that allows for more mobility, awesome. But oftentimes what I'll do in this area, if it is tender, is I'll go and I'll bowstring it. So got it here, I can just bowstring those structures just like that, kind of bowstring back and forth, just kind of working it a little bit, or having my hand going into here. just like that, just to see if there's any type of just working that just to see if there's any kind of muscular involvement or anything like that. Of course, for any type of soft tissue, you always can needle something like that. I'm open to rebuttal, but I generally will not needle these, just because I've gotten terrible results, and actually most people will flare up when I do it. I've been needled more times than I can count. The only one time it's actually made me almost pass out, and it was needling to here, so it might be my own bias, but something I kind of watch out for a little bit with that.
Big one.
I don't know. Can't do anything in this house because these kids. Alright, so let's look for the distal radial ulnar joint. Oftentimes with this, I'll just kind of talk to patients and work it again in supine. If I want to go from a P to A or A to P, you know, if I'm getting wrist extension, I want to go P to A. Kind of go in there on the actually kind of go in there on the proximals, just kind of gliding like that. Or if I want to kind of actually even get a little bit, kind of stabilize the proximal row, go into the DJ. But generally, we want to think of the carpals moving on there. So going here for wrist flexion, actually do the exact opposite, just going into there, gliding those carpals onto that. Another way that you can look at it is you can always do a distraction as well if it's pretty painful. So I can come in here and distract, come in here and distract. With these as well, you can always add a little bit of a manipulation. Again, this can be easily just go to that end range, go and just get a quick thrust, just like that. If you want to get him. So again, working if you want to go into that wrist extension, go into here, go into here. Also, you can add a lot of mobilization with movement with this, with if you want to go into ulnar deviation, radial deviation, or wrist flexion extension, and we'll show how we do that in supine a little bit later. If I want to go into a manipulation, I can always kind of come under here, kind of grasp and this, and just do a little traction manipulation. Go into there and just give a quick pull. I'm not a biggest fan of that, just because as you see how much is going with her motion there, and it's a hard position that someone's in pain. I generally find a lot more benefit working into the actual just mobilization with movements and etc. The next thing we can do, I'll show the manipulation and standing with actually the distraction manipulation. I can show it supine as well for the CMC joint, but oftentimes you can hold right here, and easily what you can do, just get here, grasp onto the distal carpal row, just lean back and distract. Lean back and distract, just like that. That's the easy way that you can do it, just to get a little bit more, but I'll show you the manipulation. Perfect. I think that's everything. Let me show you the weight-bearing mobilization movement to improve wrist extension, and then I'll also show you the radial head manipulation, the Mills manipulation.
He thinks this is the funniest thing ever.
Yeah. All right, so as you notice, we have someone who's being fussy and doesn't like recordings. Actually just wants to be a part of it. Another thing I'll show you is going to be Mills manipulation. So go ahead and face that way for me. So with this one, just go ahead and step out a little bit more. With this one, you're going to let them go the arm to the side, and what you're looking for, wrist extension, elbow extension, and actually a little bit out. So what you want to do, and it might be hard to see, is go out here and find the radial head. Just go into here, here, block it, and then just like that. So almost like a little bit of a whip to it as well. And the final one that I'll show is the CMC distraction manipulation that I learned. Go ahead and face this way and just plant your feet facing that. So go in here, get onto CMC. So my hand's coming to block right here, and all I have to do is kind of distract a little bit, just like that, and then distract and pull down, just a quick little thrust down. Sometimes I found this better, especially because we want to thrust into then pull, and that distraction manipulation can almost be a pulling one. This one, their body weight, everything's going to block out as you go down. And the final one is the wrist extension mobilization with movement. So wrist is extended. This is as far as they'll go. Used to I would do this on a ball, but I actually found that just hand flat sometimes can be better, and this can be amazing things to teach patients at home. Come with your hand. Cook will actually show like this. I've always been shown just to take your hand and just slightly just change a little bit of force there. And all you say is, can you kind of bring your wrist forward? Good, and relax, and then come out. Go into forward and relax, just like that. So as you see, again, with these, I generally will prescribe to the pill, not necessarily pain-free, but a reduction in pain and that instant, long-lasting results. And you can always get this at home, teaching them how to do it themselves. Or in the clinic, oftentimes, if we're doing things and it gets a little irritated, I will throw the Rogue Band around their wrist and have the Rogue Band do a lot of that mobilization with movement or the distraction with movement. That can be pretty beneficial if it's kind of irritated and you don't have time to stop work on it real quick.